Good morning, everyone. Thank you for joining us for today's Knockout Opioid Abuse Day Learning Series webinar, Knockout Opioid Abuse Day, evaluating recent progress to address the opioid epidemic. And for those of you who may not be aware, October 6th is designated as Knockout Opioid Abuse Day in New Jersey, and in many communities across the country. It's an opportunity to raise awareness and educate our neighbors, community, prescribers about the opioid crisis and what can be done in our homes and in our communities to raise awareness and to address this issue. So today's webinar is adding to that, and this whole series is actually based on Knockout Opioid Abuse Day and the idea that we want to continue to have those messages throughout the year. So glad so many of you could join us today. Some housekeeping. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADE CERP continuing education credit by the American Academy of CME Inc. And for any pharmacist claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJOEMS for one EMT elective CEU, and I saw a lot of EMTs checking in the chat, so welcome. Partnership for a Drug Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers, and this program is eligible for one maximum Category A hour or CEU. PA Planner Dean Barone discloses that he serves on the Speakers Bureau of Ethicon and Johnson & Johnson, and all other planners, faculty, and reviewers have no relevant financial relationships to disclose, and all relevant financial relationships have been mitigated. If you wish to claim CME or CE credit, you must do so within 30 days from today's date. After that, we'll no longer be able to issue you credit for today's event. Today's webinar is jointly provided by the Partnership for a Drug Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the New Jersey Office of Alternative and Community Responses, the New Jersey Office of the Attorney General, and the Opioid Education Foundation of America. And I give them thanks for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I am so pleased to welcome today's expert faculty. So lucky to have with us today Dr. Andrew Kolodny, the Medical Director for Opioid Policy Research Collaborative at Brandeis University. So Dr. Kolodny, thank you for being with us. We're all looking forward to hearing what you have to share, and I will turn the presentation over to you. You're muted still. There you
Sorry
go.
about that. Thank you, Angela.
No
It's
worries.
a pleasure to be here. It looks like we have more than 500 people who have are participating today, which is a terrific turnout. I am going to try and thread a needle here. I know that there's sort of a mixture of experience that people have who are tuning in today. Some people are on the front line of the opioid crisis. For others, this may be your first talk on the opioid crisis, and also we've got people from different disciplines. So I'll try to thread the needle so that this talk is relevant for everybody. So I'm going to get started. I'm going to go pretty quickly, and we'll save a little bit of time at the end for questions. I will start by saying something that should be obvious, but really isn't obvious, even to clinicians who prescribe opioids. When we talk about the most commonly prescribed opioids, hydrocodone and oxycodone, for example, we're talking about drugs that are literally made from opium. So existing in opium, in the sap of the poppy plant, is codeine, morphine, and thebaine. Another name for, excuse me, for those naturally occurring opioids is opiate. And so those molecules exist naturally, and those molecules can be tweaked. They can be treated chemically to create semi-synthetic opioids. And so, for example, heroin is made obviously from opium. You're actually converting the morphine molecule into heroin when you synthesize the the drug. The reason that cartels go to the trouble of converting opium or morphine into heroin is because when you do that, what you're really doing is creating a molecule that dissolves in fat more easily. And our brains are mostly made of fat. Our blood-brain barrier is made of fat. So when you make the molecule more easily dissolvable in fat, and the term for that would be lipophilic, when you do that, you're creating a drug that gets into the brain faster, has a more rewarding effect, more potent. The reason that pharmaceutical companies go through the trouble of converting opium into oxycodone, hydrocodone, hydromorphone, which is Dilaudid, or oxymorphone, which was Opana, is really for the same reasons that the cartels do that. You're creating molecules that get into the brain faster, that have a more rewarding effect. And something that's important to keep in mind is that the effects of heroin, oxycodone, hydrocodone, these other semi-synthetic opioids, the effects that they produce in the brain are pretty much indistinguishable. A study that was done at Columbia University several years ago, they actually took experienced heroin users into a lab setting, allowed them to self-administer different opioids, including heroin. They have a license to do research with heroin there, and they didn't tell the heroin users which was which, and then asked them to kind of rate what they liked the best. It was kind of like a blind taste test. And in that study, the oxycodone actually beat out the heroin. It wasn't statistically significant because really the effects are almost indistinguishable. But the point here is that when we talk about these very commonly prescribed opioids, we are essentially talking about heroin pills, which doesn't mean we should never prescribe them. These are important medicines, particularly for treating pain at the end of life. But unfortunately, the bulk of the prescribing in the United States to this day, despite the opioid crisis, continues to be for conditions where we're more likely to harm a patient with opioids than help them, and or prescribed in a way that's more likely to be harmful, for example, excessive quantities. So I mentioned that these are the semi-synthetic opioids. We also, as I think most people tuning in know, we have our completely synthetic opioids. These are opioids that you don't need opium to make them, like fentanyl, methadone, tramadol, tapentadol would be another. Not on this slide, by the way, but a problem that seems to be growing severe is kratom, which has within it molecules that are also opioids. Uh, the term opioid is the all-encompassing term that includes the natural opioids, opiates, the semi-synthetic, and the synthetic. Opioid really is a term that covers the molecules that activate our brain's opiate receptors. Why are opioids so highly addictive? It's because when you take an opioid, the opioid produces positive effects, which could be pain relief or could be a euphoria. And if you take a drug and it has a positive effect, that would make you inclined to take it again. If you take opioids repeatedly, then when you try and stop taking them, you experience withdrawal symptoms. And those are negative effects, and that's a negative reinforcement for stopping use. Now, if you take an opioid every day for just a few days, that is enough actually for dependence to set in. Take an opioid every day for 3 days and then stop it abruptly, there will be some withdrawal symptoms. If it was only 3 days and the dose was low, those withdrawal symptoms will be mild. Someone might not even really notice why they're feeling a little sniffly or a little anxious or fatigued, and they'll get right over it and move on. And they didn't get addicted. They experienced a physical dependence alone. But if you take an opioid every day for weeks or months and then try and stop, the symptoms can be excruciating and can make it very hard for people to ever come off of opioids. And while that dependence that sets in is not identical to being addicted, the reason that opioids are so highly addictive is because of that dependence that sets in. So, for those of you who are close observers, you may have heard some of the recent press announcing that overdose deaths in the United States have been coming down. This is very big news. It's big news because for more than 25 years now, every year we were setting a new record for the number of Americans dying of a drug overdose. And then the next year we would break that record. And in the years just prior to COVID and during COVID, as you can see on this slide, there was a very sharp increase in deaths. So the deaths have been rising over the years. You know, in 2010, the CDC was calling this the worst drug addiction epidemic in United States history, and then it just kept getting worse and worse. Beginning in the fall of 2023 is for most states in the country when we started to see deaths coming down. And so really for the past 2 years now, we're seeing deaths dropping. And the drop in the death rate has been almost as steep as it increased. And it sort of really begs the question, what's going on here to explain this decrease? And I'm going to try and answer that a bit today. I think it is multiple factors, but there's one factor in particular that I think is probably most responsible for the very sharp decrease that we're seeing. So I'm going to come back to that in just a moment. But here, this previous slide was just showing you all drugs. It wasn't showing you any sort of specific breakdown. Here you're looking at the different types of opioids. And this is a CDC slide. It says 3 waves of opioid overdose deaths. And for those of you who've attended other talks about the opioid crisis, you've probably seen this slide. And you've probably heard speakers frame the opioid crisis as occurring in these 3 waves. And when they talk about the 3 waves, what they're generally referring to here is the prescription opioid wave, where you see the sort of this turquoise blue or teal, I guess maybe line. And for what you'll see really up until around 2011, the real driver behind deaths from drug overdose deaths in the United States were prescription opioids. Then you see beginning in around 2011, the dark blue line going up, those are heroin deaths. So that's referred to as the heroin wave. And then in purple, you have this soaring in really this skyrocketing in deaths. And that was mostly involving illicitly synthesized fentanyl. So that's generally referred to as the fentanyl wave. I personally don't find it that helpful to think about this as 3 waves. And I think part of what concerns me when we frame it this way is that there's a narrative that's usually applied here to explain these 3 waves that's not really accurate. What you'll typically hear is that the heroin wave and the fentanyl wave were a response to a crackdown on the pills. That basically that government stepped in, doctors stopped prescribing, the pills dried up, and the so-called drug abusers, it's a term I don't like, but that's the narrative, the people abusing these drugs, then all switched to this more dangerous supply, and we saw the deaths go up. And that narrative is actually incorrect. It's partially correct in the sense that many of the people who are dying from fentanyl today were first addicted to prescription opioids, and we're going to come back to that in a moment. So that part about the switching is true, but the switching really started to happen much earlier. That fentanyl and heroin wave didn't begin when the pills dried up. They began when we were at the very height of opioid prescribing and opioid consumption in the United States. The peak years for opioid prescribing in the United States were around 2010 to 2014. That's when fentanyl and heroin emerged, not when the pills had dried up, but when we were really flooded with pills. And that's something really important to understand as we go over the epidemiology in just a moment. So I mentioned that I would come back to why we're seeing the deaths come down and what might be the most significant factor. And oh, actually, before I get there, I do want to just show you the latest data that's available from the CDC. I think any day now we'll get the next set of data. This comes out every month. For those of you who want to track this yourself, there's an interactive website that the CDC has on drug overdose deaths, and so this is a screenshot of that. And as you'll see where it says New Jersey, I pulled up the New Jersey specific data, but you can get this nationally or for any state in the country. And you can also sort by drug class. So what you see here is really that trend I've been describing, where we've seen this very sharp decrease in deaths, and you're seeing here this in brown, that drop in fentanyl deaths. Orange is showing you prescription opioid deaths, which really haven't come down that much. They sort of the trend is in the right direction. And blue is heroin deaths. And that decrease in heroin deaths that we're seeing across the country in many parts of the United States, heroin is gone. It's been almost completely replaced by fentanyl. But this is the trend we've been describing, and this is something that we really do want to try and understand better. Why are the deaths involving fentanyl really decreasing? And I think the best answer to that question is coming from data that the DEA is making available. And what you see on this graph, this is from the DEA's annual report. What you're seeing with the red line on this top graph, you're seeing the average purity of fentanyl in powdered black market opioids seized by DEA. And what you see is a pretty steady decline in the amount of fentanyl that's in the drugs that are being seized. And the top graph is showing you fentanyl powder. The bottom graph is showing you the pills, the counterfeit pills that are on the market. And you see as well, for the counterfeit pills as well as the powder, you're seeing that there's less fentanyl in what people are using. There's less fentanyl in the average dose that someone might be purchasing on the street, which means that there's more filler or more active cut. We're seeing more xylazine mixed in, as well as inactive cut. And so the decrease in the amount of fentanyl and the average dose that people are using on the street is probably the best explanation for why the deaths are coming down. In other words, just to bring it back to here, the reason deaths are coming down is really in many ways the same reason that the deaths went up so rapidly. We saw a soaring increase in deaths involving fentanyl, not because there was a sudden increase in the number of people using black market opioids, but there was a sudden increase in the dangerousness of that black market supply as it increasingly had fentanyl in it. And I think the steep drop in deaths that we're experiencing is for the same reason. We're seeing a change in the dangerousness of the black market supply. It's becoming less dangerous. And it speaks to the potentially effective interventions, law enforcement interventions, effective efforts to crack down on the precursor chemicals that had been making their way from China into Mexico. And this was, an effort that was launched during the previous administration, and certainly been kept up by the current administration, as well as some of the pressure overall from law enforcement on the cartels, major kingpins getting arrested, and even some of the cartels announcing in the fall of 2023, one of the major cartels saying that it was going to get out of the fentanyl business. So, as someone who has worked for many years on the opioid crisis to try and improve access to treatment for people with opioid use disorder, and I've been involved in efforts to prevent opioid use disorder through more cautious prescribing. I was hoping that the explanation for the drop in deaths would involve more or be, that really was the public health interventions that were driving this sharp decrease. But it probably the best explanation really is that the credit goes more to law enforcement. That's not to say that efforts to improve access to treatment and efforts to prevent more Americans from opioid use disorder haven't contributed to the decline. I think they have contributed substantially, and we'll talk a little bit more about that. But when you're looking for something that changed suddenly that can really explain what's happening, it really does relate more to the supply rather than to demand reduction or prevention efforts. So to let me just bring it back though to here again. So, when you're looking at when you're looking at the drug most likely to be involved in a decedent's toxicology report, and you're seeing that it's fentanyl, and you're looking specifically here in New Jersey, and you see that there's a lot more fentanyl found in a decedent's toxicology than you would see prescription opioids or heroin, which are the orange and the blue line at the bottom. One could look at this data and could say, well, why do we still have to talk about prescription opioids? Why is that even important? And some of you may be under the impression that a pendulum for prescribing has swung perhaps too far in the direction of underprescribing, and that the deaths involving prescription opioids have come down. So maybe we shouldn't really be wasting time thinking about prescription opioids or engaged in efforts to promote more cautious prescribing. And I think to understand why that really is the wrong way to think about this, first of all, the pendulum has not swung too far. I'll show you that data in a moment. We do continue to massively overprescribe opioids in the United States. But really, to understand why prescription opioids are still important, we really have to look more into the epidemiology and the history of how we got into this mess. And so this is an old slide. This is a CDC slide that was showing you this is really a slide that the CDC put together when they began referring to the opioid crisis as the worst drug addiction epidemic in US history. And that's the point they're trying to make with this graph. That box that says heroin is showing you the rate of heroin overdose deaths or drug overdose deaths during the height of the heroin epidemic. The cocaine box is the crack cocaine epidemic, and you're looking at drug overdose deaths during the height of that epidemic. And when the CDC put this together, really what they were showing you was that we had more overdose deaths by 2007 than we had at the height of those two previous epidemics combined. And what was driving that was largely prescription opioids. And so this was really, what's referred to as that first wave. But this is really what was driving the deaths. What one has to understand is that, and I think this is probably one of the more important slides in this set. So obviously, I want you to pay attention to everything I'm saying. I think all the slides are important, but if there's one thing you're going to walk away from this talk with, I want you to walk away with an understanding that we have an important epidemiology of opioid use disorder in the United States. When I mentioned I didn't like those three waves, and that there's a narrative that goes along with that, that's not correct. It's that narrative of the so-called drug abuser switching from one drug to another. It implies that we have this homogenous group of people using drugs in the United States moving from one class of opioid to another. en masse, and that really isn't what's been going on. What we have are roughly three opioid addicted cohorts in the United States, roughly three groups. The first group are individuals in their 20s, 30s, 40s. These are individuals who developed their opioid addiction taking pills and then wound up on the black market. And these are people who became addicted after 1995. And they became opioid addicted pretty much taking pills non-medically. Essentially, they were abusing the pills, taking them to enjoy the effect, and they got hooked. Or they became opioid addicted taking opioids medically. Could be a young person with a serious injury, or maybe they have a chronic medical problem. They were prescribed opioids aggressively and they got addicted that way. And another term for addiction through medical treatment is iatrogenic addiction. And then the third way that this group became opioid addicted was sort of a combination of the first two. It's where there was maybe a brief medical exposure, wisdom teeth, minor injury. The young person didn't become addicted from that brief medical exposure, but they got their first taste of the drug from a doc or a dentist. They're not afraid of it because it didn't hurt them and they like the effect. And so there's some period of non-medical use that occurs after the brief medical exposure, and then they get hooked. And of course, for that group, once they become addicted, they have to maintain their supply. And even if you became addicted because you were doing this because you like the effect, once you're addicted, you're not, what drives the continued use isn't that this is enjoyable. It's, as I mentioned, it's without the drug, you feel very sick. And the pills have always been expensive on the black market. So that younger group, group number one on this slide, wound up switching to heroin. And when the heroin supply became more dangerous because of fentanyl, we saw a very sharp increase in deaths in group number one. Group number two are people who were middle-aged and up there in their 50s, 60s, 70s, 80s. These are individuals who pretty much developed their opioid use disorder iatrogenically. They were essentially prescribed into addiction. And for that group, they also became addicted after 1995. This is a group that may be doing a bit better now, that prescribing has been trending in a more cautious direction. It's a group that hasn't generally turned to the black market because it has been able to get pills from doctors. The last group are individuals in their 50s, 60s, 70s, 80, maybe not in their 80s. These are individuals who didn't switch to heroin after getting addicted to pills. These are generally longtime heroin users. They're more likely to be non-white and urban. These are individuals who became addicted to heroin during the heroin epidemic of the 1970s. Some of them also became addicted to heroin during the crack cocaine epidemic. And so this is a group that's also been hit very hard by fentanyl entering the heroin supply. So group number one and group number three are the groups that have been most affected by fentanyl. I mentioned the switching started to happen much earlier. You see that on this slide, particularly among younger white people in the United States. You see that the heroin use really began rising in the early 2000s, not suddenly in the context of a so-called crackdown on the pills. Before fentanyl emerged, where we were seeing more of the deaths was in group number two, the pain patient, the middle-aged group. You see that here on this slide, the light blue is opioid pain reliever deaths. And where you were seeing the most pain reliever deaths was in that 45 to 54-year-old group. If you look just specifically for heroin, it was that younger group that was where you saw more of the heroin deaths, but still there were significantly more deaths in that group number two that I was telling you about. Again, when fentanyl emerges, it starts to take a very heavy toll on group number one and group number three. These are different headlines that have appeared in media coverage of the opioid crisis over the past few years. And I want to just kind of stop at this point and before I continue and try and frame the opioid crisis so that when you hear that term or when I use that term, we're thinking about the same thing. I think that for many, the opioid crisis has been thought of or framed as an overdose death crisis. It's one of the concerns again that I have about the three waves, because those are three waves of opioid overdose deaths. But I don't really think framing this as an overdose death crisis is really the right way to think about it. In my mind, that would be like framing the AIDS crisis as an epidemic of PCP pneumonia. For those of you who are old enough to have lived through the AIDS crisis, in 1994, 1995, we had about 45,000 Americans dying of AIDS. And the most common uh, acquired immune infection disease that was killing people was PCP pneumonia. And so it certainly looked like an epidemic of PCP pneumonia, but that really wasn't what was going on. What was going on was we had an epidemic of HIV infection knocking out immune systems, so people were dying with PCP pneumonia. In other words, what we were dealing with during the AIDS crisis was an epidemic of an infection that was preventable and ultimately treatable. I think that's the way we need to really be thinking about the opioid crisis as an epidemic of a condition, opioid use disorder, which is preventable and treatable, and that really needs to be, again, the mainstay of our approaches to this problem. And so when you frame the epidemic as an epidemic of opioid use disorder, what you're saying then is that the reason the United States is experiencing record high levels of opioid overdose deaths, the reason we've seen fentanyl flood into the United States, the reason we've seen a soaring increase in infants born opioid dependent, outbreaks of injection related infectious diseases, children winding up in foster care, an impact on our workforce. When you frame this as an epidemic of opioid use disorder, what you're saying is that the driver behind all of these health and social problems has been the very sharp increase in the prevalence, the number of Americans suffering from opioid use disorder. Go back 25 years, 30 years ago, before we had an opioid crisis, opioid use disorder in the United States was very uncommon. Where you saw it were in the inner city communities that had been hit hard with heroin in the 70s. Outside of those communities, in suburban and rural communities in the United States, opioid use disorder was uncommon. Today, it's an extremely common condition, and death from opioid overdose is now the leading cause of accidental death in the United States. So I've said this is an epidemic of opioid use disorder. I'm going to show you the epidemic happening with a set of slides. The epidemic began in the year 1996. And what you could see is that 3 years into the epidemic in 1999, we had a few states lighting up as red or maroon, meaning these were states that had high rates of people seeking treatment for addiction to prescription opioids. And so I want you to watch what happens to the color of the map as we go forward in 2 year increments. So you can see here's 1999. By 2001, many more states had turned red, again, meaning there was a significant increase in people seeking treatment for addiction to prescription opioids. 2003, 2005, 2007, and 2009. By 2009, in just about every state in the country, we experienced this very sharp increase in the number of people seeking treatment for addiction to opioid use disorder. And when you have a sharp increase in a disease over a short period of time, that is how you would define an epidemic. So what caused those maps to turn red? I think the best answer to that question came from the CDC, and this is another old CDC slide that I keep in in my slide sets because they really help us understand how we got here. What you could see on this slide is that as sales for prescription opioids, the green line, went up rapidly, it led to parallel increases in prescription opioid deaths, the red line, and in addiction to prescription opioids, the blue line. And the CDC's point here is that really the medical community in many ways was responsible for this sharp increase in death and addiction, that as we became more aggressive in our prescribing of opioids, it led to a public health crisis. And their message has been that the green line needs to come down in order to bring the problem under control. I can tell you that the companies that manufacture opioids, and not just Purdue Pharma, which makes OxyContin, but other opioid manufacturers have really not agreed with the CDC. And initially, as these three lines were going up together, they were paying scientists to publish articles in medical journals saying that this isn't happening. Basically, articles that said that the prescribing has gone up, but there's no evidence of a public health problem associated with the rise in the prescribing. And papers like that continue to appear up until around 2004. They were denying the trend. By 2008, they stopped denying that these lines were going up together. Instead, though, they said, hey, the green line can and should still continue to go up because millions of Americans have chronic pain and need long-term opioids. That was their messaging. But we can make the red line and the blue line go down if we make the pills harder to crush for snorting or injecting, or if we teach doctors to more carefully select their patients and monitor their patients more closely, then we can have our cake and eat it too. And of course, none of that would work, and opioids are not safe and effective treatments for long-term chronic pain. So what caused the green line to go up? I think the best answer to that comes from this slide here, that you've got an important clue because you can see the exact year that oxycodone takes off in the United States. And you can see oxycodone consumption in the United States compared to Europe. We're in blue, Europe is in red. And so you could see 1996 oxycodone really just explodes. And it's important, I'm just showing you oxycodone in the United States in this 1980 to 2015 time frame. I wish I could give you the more updated slide. I will show you more current consumption data in a moment. But I can't recreate this slide with new data on it. I can tell you the blue line, fortunately, has continued to come down. Unfortunately, the red line has continued to go up. In other words, in Europe, and in other parts of the world, opioid prescribing has really taken off. And for the same reasons it took off in the United States, which I'm about to explain to you. But in 1996, that was the year that a multifaceted campaign was launched to convince the medical community that patients were suffering needlessly because of an overblown fear of addiction. We were told or led to believe that addiction is very rare in patients who take opioids long term. We were told that patients who are on opioids can come off easily. And we were told that opioids are safe and effective for chronic pain. None of these messages were true. All of this is totally false. The notion that patients can come off of opioids easily is totally not true. Patients who've been on opioids for a while and can taper off pretty easily are the exception rather than the rule. Many patients have an impossible time coming off of opioids. Many patients are not ever able to come off of opioids. The idea that opioids are safe and effective for long-term use is false. We know, especially with data that comes from workers' comp, if you treat an injured worker's chronic pain with long-term opioids, that worker is far less likely to ever go back to work again compared to any other intervention you could have offered them for their chronic pain. We know that opioids are not safe or effective for long-term use. We have better evidence that opioids make pain worse when they're taken long-term. It's a phenomenon called hyperalgesia. Doctors would have been a lot less gullible If these messages had only come to us from the attractive sales reps who visit doctors in their offices and flatter the doctor, bring gifts for the doctor or for their staff, and if it was just the sales reps for Purdue Pharma telling doctors, "Hey, opioids are not addictive," I don't think we would have fallen for it. But the messages were coming to the medical community from every possible direction. They came from pain patient organizations that were meant to look like grassroots groups of pain patients, but they weren't grassroots organizations. They were artificially created by industry. They were astroturf organizations, front groups. The medical community heard from professional societies, the American Academy of Pain Medicine, and the American Pain Society doesn't no longer exist, but that organization trademarked the pain is the fifth vital sign, a slogan. The medical community heard from these professional societies that the risk of addiction had been overblown, that the risk of even respiratory depression had been overblown, and that we should be prescribing opioids much more aggressively. And certainly for primary care docs, when you hear from specialists in the fields of pain that this is something you need to be doing more of, that can be very influential. For anyone who's joining in today who's works in a hospital, you know who the Joint Commission is, and you know that the Joint Commission sets rules for hospitals. And the Joint Commission, in as part of this campaign, introduced new rules for hospitals across the country that went into effect in 2001 that required hospitals to treat pain like a vital sign, and not just for patients who came out of surgery, whom where it makes sense to assess somebody for pain, but for every patient in the hospital, including people who are not there for a painful condition, they had to be assessed for pain, and not just patients in beds, but within the healthcare organization in the outpatient clinics, patients had to be assessed for pain. If the way it worked in my hospital, if you came into the mental health clinic because you wanted to sit down with a social worker because you're depressed or anxious, we had to show you the smiley faces and the frowny faces before we could sit you down with the social worker. And if you circled the frowny face, the policy said refer to pain management. And you could take a pretty good guess at what that patient might get a prescription for when they wound up at pain management. And then lastly, the Federation of State Medical Boards, that's an association for an organization that represents medical boards across the country. State medical boards, the state agencies that are supposed to protect the public from doctors who might be prescribing opioids too aggressively or just practicing medicine in a reckless fashion. The state medical boards heard from their trade association that there's a chilling effect in America, that doctors really want to prescribe opioids more aggressively, but they're going to get into trouble with you medical boards. And so the medical boards heard from their trade association that they're part of the problem of untreated pain in America. Medical boards fell for it. They adopted new policies that were issued from the Federation that told doctors across America, we will not sanction you based on the quantity or doses of opioids that you're giving out, but we will sanction you for not prescribing opioids. And so, I don't want you to think that everyone involved in this movement, and it really was like a movement, was out there telling lies about opioids because drug companies were stuffing money in their pockets or giving money to these different organizations. And certainly they were. All of these groups, including the Joint Commission, took millions from Purdue Pharma and from other opioid manufacturers, the Federation as well. But it really wasn't just about money being stuffed in people's pockets. Many of the individuals involved in this movement, many of the lectures that were given that were promoting opioids, were taught by doctors or other health professionals who were really falling for the messaging. They had really bought into this idea that, opioids are a gift from Mother Nature and should be used much more for just about every complaint of pain. It's not just long-term use of opioids or opioids prescribed for chronic pain that we have to worry about. Acute pain prescribing is how many people wind up on long-term opioids. This was a study that looked at the characteristics of an initial prescription. They found that the more aggressive the prescription, the more likely a patient was going to be on opioids long term. A patient who took an opioid every day for 10 days, 1 in 5 were still on an opioid a year later. People who took opioids every day for 30 days, nearly 40% were still on opioids a year later, which means we have to be a lot more careful with acute pain prescribing. We often don't need to give opioids. This was a study that compared opioids to non-opioids for extremity fractures treated in an emergency room, and the non-opioid was just as effective. Conditions, even excruciating conditions like kidney stone pain, which is renal colic. We've known since 2004 that NSAIDs, like in IV Toradol, for example, is better than giving morphine in the emergency room for kidney stone pain, and yet we still routinely give out the opioids. Like it'd be nice if we had moved in a much more cautious direction this far into the opioid crisis, but we really haven't. This is a paper that was published during COVID. They looked at different conditions, surgical conditions, that are more minor, hernia repair, gallbladder removal, and appendectomy. And in the United States, the median number of pills people were sent home with after one of these procedures was 20 pills. In all of these other parts of the world, people were sent home with the median number was 0. They don't routinely send people home with opioids after minor surgery, yet we continue to do that in the United States. Uh, this is dental prescribing in adolescents, which is a group that may be at greater risk for developing opioid use disorder. This was a study not too long ago that compared young people who were given opioids after dental work, wisdom teeth, third molar extractions, to the young people who didn't get the opioids for the same dental work. What they found was that when they tried to look at claims data, insurance records for patients within a year of having been exposed to opioids for their dental work. For the individuals, the young people who got the opioids, you'll see highlighted at the bottom, about 5.8% of them had evidence of an opioid problem within a year based on claims data, compared to 0.5% that didn't get opioids for those procedures. So again, we really can be more cautious and need to be, particularly in that population. I mentioned prescribing is trending in the right direction, but we've kind of plateaued a bit. During COVID, we really started to see the decrease slowing down. Here's the data that was recently released from the FDA. You could see if you just focus on the dark line, you'll look at consumption of opioids measured in morphine milligram equivalents. You'll see that
From the capital, opioid documents in action. Keep haddock on opioid marketing to veterans.
Sorry, I have a little background noise here for a moment. So you'll see that the most recently available data in 2023, we're really still at about 2003 levels in our current consumption of opioids. 2003 was really puts us much higher than where we were before an opioid crisis. Deaths, as you know, have not come down as prescribing has come down because the black market supply became more dangerous with fentanyl. But we have seen, fortunately, as prescribing has trended in a more cautious direction, fewer infants born opioid dependent. What this tells us is that as we've prescribed more cautiously, less women of childbearing age are getting hooked on opioids. What this tells us is that the incidence rate of opioid use disorder, the number of people who get newly addicted every year, that number has been going down as we've been prescribing more cautiously. That number is still too high because we are still prescribing too much, but we've got good evidence that prescribing more cautiously is resulting in fewer people getting addicted. And, again, that sharp decrease in deaths is more likely related to a change in the drug supply. But overall, if we weren't reducing the incidence rate of opioid use disorder in the United States, we might not be seeing these declines. How do we bring our opioid addiction epidemic under control? I've covered this. We have to prevent more Americans from becoming addicted to opioids more than anything else. That involves more cautious use of opioids, but I also think we have to think more about kratom, which I'm seeing more and more patients who their opioid addiction is beginning with kratom. So it's more than just reducing unnecessary prescriptions, although I think that's the largest piece of it. We have to see that people who have OUD have access to effective treatment. One of the first line, I think the first line treatment for opioid use disorder is buprenorphine. I had been hoping that maybe buprenorphine explained why we were seeing that sharp decrease in fentanyl deaths. But really what we've been seeing is pretty slow and steady improvements in buprenorphine, not a sudden access that's resulting in this. But we've got to do much better in seeing that people get treated more easily. And apparently, the supply control measures have had an impact. And we really should be thinking about supply and demand as being interrelated. So that one of the lessons of the opioid crisis was that this massive increase in supply of prescription opioids led many people to become addicted and to greater demand for illicit opioids. And now we're seeing a decrease in deaths related to supply control measures. So, for many of us who work in health or in public health, we might be inclined to think, hey, the approach to drug problems is all about the demand reduction and supply, well, control. That's a war on drugs and law enforcement, and there's no role for that. I think we have to recognize that supply and demand are interrelated, and that if we're going to tackle this problem, we really do need this three-pronged approach. I am going to stop here and try and answer questions.
Thank you so much. I know you were able to tackle so much, and I know in the chat we have had a number of questions that have come up, but we'll start with this. I know we have a number of prescribers in the audience with us, and so one of the questions is with the education, and you touched on that when you talked about the education that came from industry or other sources, but what type of education should prescribers be looking to find now to help address and continue to address this issue?
I'm sorry, Angela. I was looking at the chat and not paying attention to your question. Could you repeat that?
Oh, no problem. So the question is, um, what kind of prescriber education should the prescribers who are with us today, should they be looking for in order to help move the safer prescribing or to deal with patients who have opioid use disorder, to have a better understanding of the current situation? What should they be looking for?
That's an excellent question. And I wish I had a better answer, but it's a really good question because a lot of the education that's out there is still influenced by an entire body of literature that has incorrect information in it. For example, for many clinicians who might tune into a talk, that often they'll hear that they need to carefully select patients for long-term use, maybe use something called the opioid risk tool that can tell you, that's supposed to tell you what the patient's chance of getting addicted is. And all of that doesn't work. The CDC guideline and the latest evidence review is telling us, from the federal government, is telling us that long-term use of opioids doesn't help people, and these so-called risk stratification tools don't work. And yet that's still a common element in much of the education that's out there. So, I think that I don't have a good answer. What I can say is I would avoid the FDA REMS programs, and I would be especially careful with free education, because often if it's free, it's funded by pharmaceutical companies. And so just be especially aware of the possibility of pharma influence. But unfortunately, and I would stick, if you can, to relying on Partnership for Drug-Free New Jersey, which does a lot of educational programs, the Opioid Education Foundation. If you're on this listserv, I think you'll be offered education free of industry influence.
Oh, thanks. Absolutely. And happy to continue to share any of those resources that we have. I know the poll is going to be launching soon, so we appreciate anyone's feedback on this. Andrew, can you just talk a little bit, any specific recommendations for nurses?
So, nurses work in a variety of settings. For nurses in hospitals, I think that many of them are working in settings where the Joint Commission is still having a negative impact. Many hospitals have pain management policies that result in pretty aggressive opioid use. For example, policies that say that after you've assessed their patient, if they say that based on the patient's reported pain score, they should be given an as needed medication. And often those scores are linked to being given an opioid, even sometimes for moderate pain, there are policies that say give an opioid, which is not appropriate. And so I think that if there are nurses working in settings like this, and who've taken this talk or know and care about the opioid crisis, perhaps that's why they've tuned in today, that they should really be on the lookout and trying to get involved in improving pain management policies within their settings, with an understanding that opioids are not our best, strongest pain medicines. NSAIDs are just as effective for acute, severe pain. We can't give them to everyone. Some people do need opioids for acute pain. They can't take an NSAID for a variety of reasons. But we can really be reducing opioid exposure. And I think if nurses can champion this issue within their health settings, that would really have a positive public health impact.
I know we only have about 2 minutes, but I want to get one more question in, and then I'll give you a second to leave us with a final thought. But just to add to the comment you just made about non-opioid alternatives, right? We just had a healthy aging summit in New Jersey where we talked about alternatives to opioids, non-opioid therapies. Can you just speak briefly on the role that they play and for those in the community and those who are prescribers, what kind of messaging should they be sharing or be aware of?
So I think the messaging should be that we need to avoid round-the-clock use of opioids and use every other possible alternative. Opioids can be helpful if they're used intermittently for some people with chronic pain, especially those who can't take an NSAID. But if you're taking an opioid every day around the clock, tolerance and dependence set in, and you're more likely to wind up with an increase in pain. We have an array of modalities. It's not really possible to say if not opioids, then give X, because there are many different reasons that people suffer with pain or chronic pain, and so they need approaches that are targeted for their complaints. I know there's a lot of interest in suzetrigine, which is a new um, uh, analgesic, a new non-opioid. It's indicated for the treatment of acute pain and may be helpful for some people. NSAIDs are probably still going to be first line for acute pain, and suzetrigine is not indicated for long-term use. We could use better tools, but we also have a lot of options available to us right now for helping people with acute and chronic pain that don't require opioids.
So, final question. One thing before I go to you with that final question, I know there's a lot of interest in the chat on the Crotum that you discussed, and we will be having a webinar that's going to be discussing that specifically in December. So I just wanted to make note of that. But Andrew, a lot of us who are on the webinar today are hearing a lot of a narrative that this crisis is over and that we need to move on to different substances, right, that may cause addiction or other issues past the addiction and opioid crisis. So if you could just your final thoughts on that and how what your perspective is on that narrative and also how you would recommend a response to that.
Yeah, so the fact that we are seeing a sharp decline in opioid overdose deaths in the United States is terrific. And it gives us reason to be hopeful that this crisis will ultimately come to an end. But there's nothing really to celebrate yet when we have about 80,000 Americans dying from drug overdoses every year, most of which are opioid overdoses. And I don't like to focus too much on the deaths, but that with 80,000 drug overdose deaths a year, that's about double the number of Americans dying from a car crash. If you went back in time, the number one cause of accidental death in the United States was overwhelmingly a motor vehicle accident. We have still double the number of people dying from drug overdoses, opioid overdoses, than from car crashes. And so this is still a really urgent problem, and the deaths are the tip of an iceberg. We have millions of Americans suffering with opioid use disorder, which is life-threatening, but also has an impact on the individual, on their family, on their community. And so we still have a lot more work ahead of us.
Well, thank you for your time today, and thank you for helping us prepare for that work that is ahead of us. We appreciate you being with us. Appreciate the time. Everyone who was on with us as well. I know we went over a few minutes, but I appreciate so many of you sticking with us. Information on how to obtain continuing education credits is on the screen in front of you. A copy of the slides in this recording will be available on knockoutopioabuse.drugfreenj.org later today, and information on the upcoming webinar for November, the biology of addiction, which will be held on November 13th, is also available on the screen in front of you and also on that website. So once again, thank you for all of our attendees for joining us today, for your commitment to this issue, for helping us to really continue to focus on the opioid crisis. And thank you, Dr. Kolodny, for sharing your incredible information and expertise with us today. We appreciate you being with us. Thank you, everyone. Have a great day.